Good afternoon, dear delegates. I am extremely happy to present here. Once again, all doctors I would like to welcome, and I would like to I would like to call Dr. Sachidanand Sir, President of IMPA, and to give a feedback, introduction and feedback.
Good afternoon, everyone. I welcome you. Good afternoon, everyone. I welcome everyone for today's meeting. I'm thankful for our sponsor, Chennai. Now I request Dr. Kailash to introduce the speaker. Good afternoon, ladies and gentlemen. I'm extremely thankful to all the delegates who have come in such large numbers to hear an important topic of hypertension. In fact, last meeting also we had a huge number, like 70 people. Now also we have a number of about 60. Hypertension is also as important as asthma, because nowadays over fashion, I have blood pressure சொல்லிக்கிறதே ஒரு fashion எல்லாருக்கும் patients எல்லாருக்கும் எனக்கு BP சக்கரை அதோட ஜாஸ்தி எல்லாருக்கும் எனக்கு சுகர் இருக்குப்பா அப்படிமா. So hypertension is such a common thing, and we have Subash who is going to give some inputs on myths and facts on hypertension. இப்போ நான் ஒரு recently ஒரு WhatsApp article பார்த்தேன். There is nothing like hypertension போட்டிருக்காங்க. As you grow older, your pressure will go up, and it's normal. Don't try to suppress it. I really want Subash to highlight on that particular thing, because 140/90 la na vandu aggressive treatment potati vandu you must take tablet solranga. Is it necessary na enak puriyala. 140/90 I have to take on. So maybe all these questions will pose to you. Now we must thank Glenn also for arranging this wonderful meet. Lovely lunch, Tamim. Wonderful. So I'll just introduce Dr. Subash Chandar T. He finished his MBBS, MD and DM all from Sri Ramchandra Institute of Higher Education Research. From 2006 to 2019, I finished your DM cardiology. He finished DM cardiology. In fact, her professor is also here, Dr. Subash. So she just the professor is here. Now, his expertise and experience are he was a registrar in Department of Cardiology in Ramchandra Medical College till 2019. And subsequently joined Apollo as a consultant, associate consultant for some time, about a couple of years. Then he started working in Cancer Institute as a consultant cardiologist, and also works in his own hospital, Venkataeswara Hospital in Nandanam. He does all the interventions, procedures in Venkataeswara Hospital. So a few words on the expertise he has. He has in cardiology, non-invasive and invasive procedures he does regularly. The non-invasive services which he does are transthoracic echocardiogram, transesophageal echocardiogram, carotid Doppler, 24 hours Holter monitoring, 24 hours ambulatory blood pressure monitoring, and many such things as non-invasive procedure. In invasive services, intra-aortic balloon compulsation, intra-aortic balloon count. What is it done for? Oh, okay. Coronary angiogram, which is written, percutaneous transluminal angioplasty, stenting and all this stuff, percutaneous balloon mitral valvotomy, then permanent pacemaker implantation, implantable cardioverter defibrillator, his bundle pacing. Whose bundle? His bundle, okay. His bundle pacing. Okay. Then, of course, he has numerous publications in a lot of cardiology magazines and all that. I have a huge list. We can't read now. Presentation, of course, post-presentation he has done a lot in Ramchandra Medical College during his MD and DM. Subsequently, he has given lectures in the Tapicon. Tapicon is Tamil Nadu, like Apicon. Tapicon is one for cardiologists. And national cardiologist meeting also is done. He has numerous theses. One of them is acute kidney injury, severe sepsis, and clopidogrel resistance in South Indian population. Is it resident? Oh my God. Okay. Numerous conferences he has attended, both in cardiology and other things. And today, of course, we have a very important topic on myths and facts in hypertension. I want you to keep your cell in silent mode, so it doesn't interfere. Keep your questions. Do you want them to ask questions then and there or at the end? Then and there. Only then we'll remember. All of us are senior citizens here. So I request all of you to ask the question. Raise your hand, he'll answer the question. So you don't have to wait till the end. You can finish off. But within, I promise you, we'll finish the Pardon? Yeah, I've already asked. We'll try to finish off this lecture within an hour. With the question and answer session also. If possible, it will extend for an hour and a half. Okay. So with this small introduction, I request Subash, Chandar, T to go with the presentation.
Thank you, sir. Good morning and good afternoon, everyone. Hello, madam. Long time I haven't seen you. So today we'll be talking about systemic hypertension and the common myths and facts what we see. Am I visible? I'm not seeing the screen. Okay. So hypertension as a whole. So systemic hypertension is a part of the spectrum of non-communicable diseases. Unfortunately or fortunately, it's an asymptomatic disease. So most of the patients who end up having hypertension do not reach to a doctor or to any healthcare services. They're incidentally identified. So it is incidentally identified in patients. It is hard to tell a patient who has no symptom, though you have a disease, or you have to take medicine. And it is even harder to convince them to come back on follow-up and treatment as well. So today we will talk about some of the random, absurd, sometimes questions they might ask. How we explain what we put forth. So the first misconception is high blood pressure is only BP of 140/90. Only at 140/90 do we start treatment. So guidelines change every year. There's a new guideline. Yes, it is, sir. I'll tell you why. So guidelines change every year. Previously, it used to be only 140/90. Right now, the guidelines have changed. We start treatment with antihypertensives even earlier. So this is the World Health Organization recommendation, which is almost the same for the next 3-4 years before they change again. The recommendation is any patient who has hypertension or BP of 140/90, we start treatment on weight. But patients who have a BP of 130 with evidence of end organ damage, you start treatment earlier, or who are even at higher risk. Say they are diabetic, they have chronic kidney disease, they prior history of TAS. All these patients who are at a higher risk, we start treatment earlier. We don't wait till the BP goes above 140. Even at 130, we start. Do we take only one number? No, it doesn't matter. Any one of the numbers, systolic and diastolic matters. Diastolic more important than systolic. We Indians specifically have this thing about isolated systolic hypertension. Those are the patients we also have to target. Now, I have symptoms. Yes, sir. So that the explanation is simple. So BP systolic is different. The diastolic means different. Diastolic is like the continuous perfusing pressure of the organ. Systolic pressure is just a spike which goes up. The PVR, so the persistent injury is more, this is the easiest, simplest way to explain it. So persistent injury is more concerning than individual injury. So if we bring down the diastolic pressure, it is more significant also. Another common misconception. So, I have no symptoms of BP. Should I start treatment? I have no symptoms. You incidentally told me you have BP. So, how guidelines work is they don't start antihypertensives in the first visit. Most of the patients who end up sitting in front of us in the clinic, they have white coat hypertension. They see us, the BP shoots up. What we actually say is, do not check. The patient comes to us. You sit in front of us, talk to them. Leave a couple of minutes, let them rest, let them be calm, let them not have their arms crossed, legs over crossed, nothing. Let them sit for a bit and then check the BP when they are calm and collected. The chance of you picking up white coat hypertension slightly reduces. Even then, a single recorded pressure is not recommended. We recommend measuring the pressures again in the same sitting 10 to 15 minutes later. Or if not possible, tell them to wait half an hour, recheck the pressures. This is for first identification. If the pressures are persistently elevated, then we can label them as hypertension. We have obvious proof. Symptoms are always a delayed sign. By the time symptoms start, usually the symptoms are of endocrine dysfunction. That means you're going to have a stroke. Why are you waiting for BP to develop? Only if the leg swells up, will I start treatment. I don't have BP. I feel uneasy, that's only I have BP. Those are all signs of impending vascular events. Those are all later signs. We don't wait for them. We try to aim for the asymptomatic patient. So this is where the iceberg phenomenon comes in. Yes, sir.
Idea diastolic will correlate to the coronary, suppose 120, 150 by 120.
So when we grade hypertension, sir, we talk about hypertensive emergencies, urgencies, and just asymptomatic versus isolated hypertension. If the diastolic pressure is more than 120, it strongly correlates with vascular events, sir. It correlates in the acute event, in the chronic event. In the chronic event, there is accelerated atherosclerosis happens. There's a correlation between carotid intima medial thickness and because we cannot check for angiogram for every patient who comes into the OP for vascular disease.
It could be persistent, because already event is happened, 120 will persist.
So the thing is, sir, event will occur anytime. Patients who are going to develop events are going to end up in the emergency room. The patients who come to us have not yet developed an event or have had an asymptomatic event and after. Any patient we see, we assume they're going to develop an event. We control the pressure, irrespective of what their illness is or not, except for an acute stroke event, IC bleeds. Except for those events, we always aim to bring the pressure down to preferably less than 130/80, or if possible, in older patients above 80, 140/90, and this side. Yes, ma'am. So, mercury manometer is gone because of risk of mercury toxicity, disposal of mercury issues, all those things. But mercury manometer is gone. We currently use only aneroids, or we use guidelines actually recommend automatic BP apparatus provided they are periodically calibrated. Those are better, easier, and considering the number of patients we see, it is easy also. And point two, home BP measurements. We recommend it. Measuring BP at home is strongly correlated with better outcomes, because one, they check the BP regularly. If the BP is high, they say, okay, something is off, I'm coming home. That is a positive way. The another problem is none of the machines, home machines, are calibrated. When they buy it indefinitely, and then we don't even know if they're using it properly.
Who's calibrating all this?
It has to be taken to a biomedical engineer periodically once a year, calibrate go off. The ideal world does not exist, sir. So we take the just if the BP is high at home, easier to bring them over, recheck. If the BP is okay, reach 30 minutes later, then send them home. That is it.
Now we sensor battery. You have a pin attached to it. You can directly connect to the current. That is better than the battery.
So the thing is, how we use doesn't matter. What method of BP measurement matters. There is these newer non-compressive, non-invasive measures of BP which works only on pulse, the pulse waveform which it is right now not recommended for community surveillance, and there are a lot of variations how it works. Therefore, it's not recommended. So we have seen those in the materials. Those ones. Oh, that is always wrong, sir. That is always wrong, sir. So please recommend the regular compressive method. Yes, sir. The problem is, even that machine is not calibrated. So it is okay to recommend home measurements of BP, provided we tell them don't be alarmed. If anything, let us know. We can return them. Otherwise, they'll check in the middle of the night. BP will be high because they just woke from their sleep and then they rush to the emergency. It is very common, unfortunately. So again, as I was saying about these symptoms, iceberg phenomenon. More than symptomatic patients, asymptomatic patients are far more. Now, this is an article which was published, which depicted in an emergency emergency room. What I noticed was 4 out of 10 patients who came in with a different illness. This is a pretty old article, actually, 2005. 4 out of 10 patients who came into this room had high BP. They did not present for any, so they excluded all hypertensive emergencies. They excluded all stroke patients. These were otherwise asymptomatic, trauma, fever, otherwise illness. Patient comes in, 4 out of 10 patients ended up having hypertension. The same article they also examined for OP patients, where they identified 3 out of 10 patients. This was all in 2005. Subsequent data exist. 47% were identified to be asymptomatic hypertensive patients. So these are the target populations which we have to identify. Patients who are already coming in, we are going to give them medication, that's fine. There is still a significant chunk of the patients who are at home, sitting, doing nothing, unaware. They develop a stroke, and only then we pick up. They develop a heart attack, we pick up. Developing a vascular event is what we want to avoid. at all times. The whole point of control BP is to make sure that index event is avoided. If you can avoid, anything and everything is better. Oh, I have high BP. Someone told me I have BP. I will right now cut out salt. Can I be without medications? That is another common misconception. So let me talk shortly about salt. Is salt inherently bad? I'm going to slightly change to Tamil. மனுஷன் காட்டுல மிருகமா இருக்கப்போ உப்பு போட்டு சாப்பிட்டதே கிடையாது. உப்பு எதுக்காக வந்துச்சுன்னா அந்த ஃபுட் ப்ரிசர்வேட்டிவ் இல்ல ஃபர்ஸ்ட் வந்தது ஃபுட் ப்ரிசர்வேட்டிவ். சாப்பாடு கெட்டு போக கூடாது, அதான் புளியோதரோட உப்பு அதிகமா இருக்கு, எல்லாத்தையும் ஊறுகால உப்பு அதிகமா இருக்கு, ஏன்னா கெட்டு போக வைக்க கூடாதுன்ட்டு. ரைட் நவ we are in a world we don't eat old food too much, or இருந்தா கூட ஃப்ரிட்ஜ் வச்சு சாப்பிடுறோம். So the concept of salt as a preservative is technically gone, but sadly salt chemical as a preservative has changed into taste. சாப்பாடு கூட டேஸ்ட் வருது. The palatability-காக we started changing the increase of salt. Now the recommended intake guideline of salt intake is 2.3 grams of sodium. 2.3 grams of sodium is not possible for us to measure. So approximately in our table salt we say around 5 grams. 5 grams, 1 teaspoon correct. This is added salt. The thing is every food has salt in it inbuilt, which we are not measuring. So we have compromised. We need added salt in our food. We do not. If you're not on a diuretic, you're not doing anything, and we don't do extra excessive sweating physical labor where we are using sweat salt and all. We do not need added salt. If you can do a salt-free food, it is excellent. You will have no problems. You will be ideal. You don't see cows. Salt is not needed for only for palatability. We compromise saying restrict to 5 grams. That is 1 teaspoon of salt. Now, there is even a study for this. These are all interesting articles. There is a separate journal called Appetite, which is a nutrition journal, where they saw if you are used to lower salt, the palatability is completely gone. You are okay. So they actually proved in that thing in South Africa too, that if you can go up to 1 or 2 grams, once you get used to the first 1 month of low salt food, you can do well. You tolerate well. Systemic hypertension drastically drops, 20% drop. Why doesn't it go into any guidelines? Because I cannot go into a community say, oh, eat without salt, you're going to be all right. Their patient is not going to come back. I would rather eat salt and live for 40 years than without salt for 100 years. We compromise in the middle of 5 grams. 5 grams of added salt. But there is all these other food items which we do not calculate. Urga, mixture, we are able to keep on the shelf. Everything has salt. We also have to measure that. If you can only ideally exclude all of those, you can stick to the 5 grams salt recommended. Okay. Now, these are multiple trials. Everything showed it is possible if you can cross the 1 month. That 1 month is a golden period, Mari. If you can cross the 1 month of low salt palatability, then after that, even if you add salt, you will hate life. So, on the 1 month, I will cross பண்ணிக்கிறோம். The salt 5 grams and lesser is recommended also when you're not on diuretics. If you're on a diuretic, you're walking out there, sweating work, then it may adjust as per that. That's a different story. Now, we will talk shortly about something called potassium salts. So the common salt we eat is actually just sodium chloride, so other salt equivalents. Other recommended salt intake is 5 grams, 2.3 grams and 5 grams of salt. More potassium salt you can take more. Potassium salt slightly tastes different. The sodium free salt being vikiraga sir, all of those things are ideally supposed to be potassium salts. If you have potassium salt, you can take up to 8 grams per day. You almost double the salt intake. But the issue is, in Indian scenario, the potassium salt intake is heavily adulterated. Potassium salt in and we have no means of checking. You cannot take the sample every time to ICMR to please check if it's so. So ideally, in an ideal setup, we can recommend switch from sodium regular raw salt, whatever salt you're taking, to potassium salt. But the problem is, in India, we cannot recommend it. One, because of that. And second, it is not recommended in renal failure patients who have arrhythmia, diuretics, because potassium intake increases the risk of arrhythmia, but that is a very negligible population. In the future, that may change. We may actually have a standardized lab which will say this is true. Now, I'm drinking coffee regularly. If I cut off coffee and my BP reduce. So the difference between caffeine intake, acute intake of caffeine and chronic intake of caffeine. If you're acutely taking caffeine, there is a rise in BP. The rise in BP can be as high as 3 to 4 systolic or 430 in not case. This is an acute intake, but paradoxically, in long-term caffeine intake patients, it does not matter. Intake or lack of intake of caffeine has no result on the pressures in long term. Any amount of caffeine a day has nothing to do with the BP, sir. So, yeah, it's your wish. Makes no difference. Pressure control point, salt, diet wise, that is essentially one thing.
Salt, the rock salt as purified salt.
We'll come to that. That is more next. Oh, this is another thing we commonly see. Oh, I saw a doctor 5 years back. The doctor said I had BP. They gave me medicine. I've been taking the same medicine. Check-up போனீங்களா போல கடைசி எப்போ பார்த்தீங்க 5 வருஷம் ஏன் பார்க்கல மாத்திரை எடுக்கிறேனே நல்லா தான் இருக்கேன் எதுக்கு போகணும். How often do you have to check up? If you assume an antihypertensive is given, is it the same? No, the thing is every single pulse waveform we have has a different systolic pressure. The problem is what we measure may not be the actual ideal measure. Ideally what we're supposed to do is we're supposed to measure 3 to 5 times and average it, which is not feasible in clinical practice. Ideal recommended guidelines is different. US it's different. This is the Indian guidelines what they recommend. If a patient comes to you with high pressures right now, you will ideally tell them to revisit every second weekly or monthly till the pressure comes under control. Once it comes under control, preferably once in 3 months or once in 6 months, good to have a follow-up. The once in 6 months recommendation is only if they're consistently under control for a whole year. And then you can switch over to once in 6 months. Oh, I am young. Pressure I am only 20, I am only 18. Now, the youngest person I have seen with hypertension and had a heart attack is 22. So, that misconception for me was gone. This is the US guidelines. Indian guidelines do not exactly exist for young hypertensive evaluation or follow-ups. The US guidelines say start screening when you're 18 itself. But the recommendation is only once a year screening is enough. Because the incidence among 18-year-olds is still significantly. They had an incidence of around 15 to 20% of hypertension. 18-year-old with hypertension. 10 years back when I was in college, it would have been unheard of. Now it is very common. Every IT professional which comes to us has pressure right now. So recommended. So right now for common end organ damage screening, we say 3 to 35. But basic illness screening has to start from the age of 18, preferably. I'm not talking about pediatric population because pediatric population screening is entirely different. They recommend every visit to the hospital, check your pressures are being taken. That is how it goes. Now, this was the latest guidelines I could find about the Indian data. And this was also quite ambiguous. They encompassed every patient between the age of 15 to 59. They had a data of about incidence of around 11%. So this is the closest data we have for presence of hypertension in young patients. It's around 11%. So my BP, I have BP medications. Can I manage this without exercise? Or I take medicines, I don't exercise. Both combinations, we'll talk about it. Whatever we say, whatever medicines we give, or everything, TB medications, or BP medications, sugar medications, even acetron for vitamin K or mechanical valves, the drug compliance is said to be only 60 to 70%. So 30 to 40%, even when they have an active illness, or even for an asymptomatic illness, they skip medications. Or they don't take medications. They say, patients in hypertensive spectrum, when they stop medications or don't take medications, their pressure rise is significantly higher. One day. Point 2. When you take medications but don't control your diet, you still continue to drink alcohol, you continue to have significant salt intake, then there is a 64% chance of therapeutic failure. So is there a clear number? This is the only data we have of saying without medications or who do not have proper compliance issue. And this has to be taken with a pinch of salt because this trial was done with recollection method. They went back to the patients and asked, Do you remember taking medications? So memory is always a doubtful thing. This is the closest data we have suggesting 64%. If you do not control your salt, if you do not take your follow-up, everything, treatment failure will occur. The consequence of end organ damage, everything will occur for 64% of the time. So, BP medicine is being taken. 6 hours, every yearly follow I'm going. Pressures are okay. I'm going to stop medications. மாத்திரையை ஸ்டாப் பண்ணலாமா அப்படின்னு கேட்பாங்க. What happens? Now, there are multiple things we have to talk about over here. We'll talk about this one. When you claim a patient comes to you and they ask you when medications be stopped, we ask for 4 separate things. First, are you working daily? We recommend at least an hour of walking every day, at least 5 days a week. If you're doing that, we'll think about it, because systemic periodic exercises can bring your pressures down by 5 to 7 millimeters of mercury. Point 1. Second, dietary restrictions. So one example, the DASH diet. There's a multiple diets. The simplest way, are you controlling your salt? If does obviously when you control your diet, there's a significant BP drop. Of all methods, that's the most highest BP drop. Next. Previous. Okay, so third thing, sleep. Are you sleeping 7 to 8.5 hours? If you can target that. Point 4, weight loss. If you achieve all of this and you have normal pressures, then it makes sense. Most patients will not. Something or the other will be wrong. If only only all of these have been achieved, can we talk about reversing hypertension? Reversing non-communicable diseases is a separate illness. Now, if you can achieve all of this, it's possible to come down. But the possibility of being off is only 50%. Despite of doing all of this, by the time we diagnose these patients, they already have irreversible perivascular injury. There will be arthritis going on. There will be they will have hypertension again. Those are patients who, even after doing that, even after they've lost weight, we will still have to take medications. So only 50% of the patients who have achieved all 4 can be said to say you can be without medications. So, easiest way, sir, salt over the diet. There are multiple other things. There were other things I'll explain to you, sir. But simplest way is salt over the diet. Next. Now, this was a curious thing. They've identified if you have increased beetroots in your food, there's actually a significant chance of pressures to be reduced. They measure up to 2 to 3 millimeters mercury drop if you actively add beetroot into your regular meal. One explanation they explained was because of possibility of nitrates in the food. The nitrate in the beetroot is reason for it. Now, let's talk about sleep. What is an ideal sleep? So, it actually formed a unique parallel. So, the ideal amount of minimum sleep is 7 hours, maximum 8.5. Anything less than 7 is bad, anything more than 8.5 is bad. If you can achieve 7 to 8.5 hours of sleep, somewhere in the middle, that is the ideal thing. Now, the problem is, does it matter, deep sleep? REM sleep போனேன், ஆழ்ந்த தூக்கத்தில் இருந்தேன், எனக்கு ஆழ்ந்த தூக்கத்தில் 6 மணி நேரம் போதும், 5 மணி நேரம் போதும். Does not matter. We do not have a proper method of measuring it, which can be clinically reproducible every time, and every night you sleep is different. On an average, 7 to 8.5 hours of measurable sleep is good enough for us. So it has to be ideally a continuous sleep, sir. That is why even if the patient has one episode of nausea, myself personally always start the patient on Unimax or something, in male patient. It is not worth it. Ideally, continuous 7 hours of sleep is required, sir. It is difficult as you get older. This target is more slightly for younger, 60 and below, sir. Once prostatanoid sets in, every episode night there will be one episode of it. It is unavoidable. So I will come to that, sir. After that sleep, I will talk about that also. So, as I was saying, ideally this has to be achieved 7 to 8.5 hours. The thing is, this is more for patients who are trying to prevent hypertension from developing. 20-year-old, 30-year-old, 40-year-old. Only in the 30s and 40s you are sleeping well. At 60s you will get to a point where you will be without an illness. Once your illness sets in, it does not matter how much you sleep, your illness is already there. It only reduces the mortality, reduces the complications while sleeping is adequately at that time. Point 1. Point 2. As a sleep deficiency, It can result in other illness. Weight gain, obstructive sleep apnea, those ends up occurring, and those will directly affect the sleep. It becomes a vicious cycle over that point. So only and only if you achieve all these four, we can say. Next. Oh, previous. So how do we tell patients how do I sleep, what to do? I recommend all my patients to switch off your screens, phones 2 hours before sleep. One, primarily because of blue screen. Blue screens are inherently bad. Even if most of the phones now have a night mode where the screens become yellow, that is because they switch off the blue light. That's a blue light filter. Because the pineal gland, the day-night cycle disturb agakudadunu solittu. But even then, there is still some effect on it. So what we recommend, 2 hours before sleep, switch off all screens. Preferably in your room, there should be no TV, no nothing. If possible, leave the phone outside or leave it on silent. Nothing in life is worth waking up in the middle of the night to treat it unless you are on an emergency call. Point 2. Before going to sleep, consciously wash the blood, and no water should be taken 1 to 1.5 hours before going to bed. And just before going to bed, consciously wipe the bladder. Next to your bed. See, another problem is sometimes patients wake up in the middle of the night, they will pass urine. Even if waking up once is manageable, when they wake up every hour, every second hourly, these are patients who have trouble. One reason can be because they keep a cup of water or a bottle of water at night. Every time they go to the bathroom, they come back, drink water and sleep. And then they'll want to pee again. So we recommend keep 1 cup of water just to keep your mouth moist. Not enough to free yourself. And then go to sleep. Ideal sleep has to be in a dark room with no noise, no sounds. Having white noise machines maybe for different people, that is off-label recommendations. But prefer. So people sometimes cannot sleep in an empty room, sir. So they have these machines which will create noise, fan noise, letting the background noise. These are white noise. They just stop your background. That way your mind is not thinking about sleep.
Noise cancellation.
It will always move in your sleeping, sir. So it is uncomfortable also. We recommend people not to have anything obstruct in the sleep. The biggest problem with sleep apnea machines is it obstructs the way they sleep. They find it difficult to think. So that is why we started using all these mandibular advancement devices trying to combat sleep apnea at the early stages. If you can catch it at that point, it is easy. But once they get to a sleep apnea machine requiring point, it is unavoidable. You have a machine attached to you. And we cannot afford those fancy American machines which is like small. Now, most machines that we have is a face mask with tube connected to a machine on the side. So, ideally, it has to be an unobstructed sleep. Nothing on you, nothing on your face, nothing. There is an easier way to sleep. That is what we recommend. Now, I use pink salt. It's healthier. They are selling, oh, can I do pink salt, sir? Or there is bamboo salt, which is more expensive. How many of us over here use pink salt? You've been making some people very, very rich. It matters not. This is the price difference between regular salt versus pink salt. It is a pure marketing gimmick. The original pink salt was supposed to come from hills of the Himalayas, not on the Indian side, but on the Pakistani side. None of it is mined there. It is all regular salt which has been dyed pink over here. Now, it matters not. Salt and the end of the day is salt. Because the quantum of salt intake is so minuscule, any theoretical electrolyte or anything what we could take extra from it is insignificant. It is better, easier to get those nutrients from vegetables and anything else rather than a salt additive. And the amount of salt additive we need to take to have those electrolytes is huge. Kilogram kanakkil, which is not feasible. So my recommendations, please avoid pink salt. It has no use. Now, is there a difference between rock salt, powdered salt? The only difference is iodization. If it's a young child, we don't want any iodine deficiency, it makes sense. Otherwise, again, makes no difference. Powdered salt or rock salt is essentially the same for the sake of hypertension. Oh, I take a 1 cup of peg every night. Can I continue to do it, sir? Will my BP be affected? Now, it helps me adjust my sleep, blah, 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 blah. Now, there is no quantum of alcohol which is safe. Any amount of alcohol intake increases cancer risk, it increases the risk of heart disease, it increases the risk of all damages and illnesses. previous thought of us used to be one cup of wine once a week. நல்லா இருக்கும் அப்படின்ட்டு. Indians unfortunately have this bad gene in us where one cup of wine becomes one bottle of wine every day. We are all prone to addiction. We are just addicted to something else. Either we are addicted to alcohol, or to work, or to food, or something else. Indian gene for addiction has a genetic basis, and we are easily more prone to this. So there is no amount of alcohol we recommend. Yes, sir.
What made Indians genetically prohibited? What led to the evolution that made them like this?
So the thing is, sir, there is actually a nice article during that I read. I'm going to slightly switch to Tamil. So Indians came up post-British versus pre-British is different. This was made from all the bones which they found. Manushanga, Indians are better suited for families. பற்றாக்குறையில நம்ம நல்லா இருப்போம். We are healthier. நமக்கு சாப்பாடு கம்மியா இருந்தா we are far healthier. ரோட்ல போறோம் எல்லாம் இழுத்துட்டு போறோம்லாம் பார்த்தீங்கன்னா 6-pack abs-ஓட நல்லா ஃபிட்டா நடந்துட்டு இருப்பாங்க. The reason, one explanation anthropologists were able to give was the multiple famines which came in during the British occupation. All of this made us genetically more leaning towards where we can survive better in less. We are not used to excess. If you have anything in excess, it becomes bad. வெள்ளக்காரன் they eat slabs of meat. அவன் daily steaks சாப்பிடுவாங்க. ஒண்ணுமே ஆகாது. We look at meat once a week, we end up developing cholesterol, heart disease, எல்லாமே. The reason they claim is because of the periodic famines and the extreme degradation of humanity which occurred during the British occupation is what they claim. There is no way to prove it, but this explains more.
How was it before that? Have they done the research that you compare and contrast?
So the thing is, sir, we lost all our knowledge. We don't have any proof. What we have is in stones. Stones don't talk about wealth. They talk about the daily, day-to-day life. The only proofs we have is native food, what we used to eat. For example, அரிசிக்கு இட்லிக்கு வரேன். ஸோ இட்லிக்கு நம்ம போடுறதுப்போ அரிசி 3 பங்கு 1 பங்கு உளுந்துன்னு போடுறோம். அதனால நல்ல உருண்டையாக ஃப்ளஃபியாக வருது. நல்ல ஃப்ளஃபியாக வந்து we assume it's normal. Previously it was not that. It used to be 1 to 1 பங்கு இருந்தது. உளுந்து அதிகமா இருந்துச்சு. ஆக்சுவலா கர்நாடகாவில் இட்லி வாஸ் ஒன்லி உளுந்து, வேற எதுவுமே இருக்காது. என்ன ஒரே தோசை கொஞ்சம் மொத்தமா இருக்கும், அவ்வளவுதான். It is slightly better because we are not meant to eat such carbohydrate. We don't need that much carbohydrate. We are not doing that much physical activity. Even before we are doing that activity, we didn't need that much carbohydrate. If the only way to identify that is go back and see the native food what we used to have. Native foods did not have this much rice, grains. We had more vegetables, we had more millets, we had everything else. இந்த பச்சை போயிடுச்சு, கிரீன் ரெவல்யூஷன் எடுத்துட்டு வந்து எல்லாத்தையும் அழிச்சிட்டு அரிசி போடு, நெல்லை போடு, நெண்டியத்தை போட்டு விட்டாங்க. எவ்ரிதிங் எல்ஸ் டிஸ்ட்ராய்ட். If we notice, தாத்தா பாட்டி காலத்துல they did not have this much diabetes. One reason may have been the impact of rice did not come into them yet. Now we are actually seeing the rice impact, wheat impact, and also chemicals. The thing is that there is no way to prove it, there is no way to disprove it. Even if you have data, it gets selected on it. How do we talk about it? So easy way. I cannot tell you to go grow your own grains and eat it. Have native. The only thing I can suggest is go back to native eating methods. That is ideal. அவிச்சுதா சாப்பிடுங்க. That is better. புரிச்சது எதுவுமே வேண்டாம். உப்பை கம்மி பண்ணிக்கிறோம். Simple way. Either way to prove simple. You do not need to eat 3 meals a day. Having 1 meal a day is more than enough. Your body can survive well. And Indian body survives better when we have lesser. 3 வேளை பிரிச்சு சாப்பிடணும் அவசியம். As per thirst, as per hunger, eat. Don't get a habit. Push down the rice consumption. That will be the easiest way. Push down the rice consumption. That will be the easy way. Avoid alcohol in all forms. There is no amount of alcohol which is good. And we are also more when my grandfather did not know any single person with cancer. Now I know so many. I'm not as a doctor, as a friend I know so many patients with cancer. That is just a stark difference in the nutrition, diet, lifestyle, what we eat. And there is also this concept of air pollution. Now That is something which we have absolutely no control. இதுவாது நான் அரிசி செஞ்சுக்கலாம், இது பண்ணிக்கலாம், we can source some form of native. There's nothing you can do about air pollution. The mask we use is insufficient. Now, he was recently in a trip to Japan. Our air quality right now in Chennai is around 108. It's a holiday, it is around 108. We claim air quality index of less than 50 is good enough for it. When I was in Japan, Tokyo, the capital, our equivalent of Delhi, their air quality index was 25. And they called it, oh, it is so polluted, we don't want to go out. அவங்க கியோட்டோ, ஒசாக்கா அந்த மாதிரி 2-3 சப்சிட்டிஸ் இருக்கு, மதுரை மாதிரி ஒன்று. அங்கே the air quality index was 1, 2, 3 சிங்கிள் டிஜிட்ல. அதுவே இது ஏன் இருக்கு அப்படிங்கிறாங்க. The thing is, the politicians, the state has other control that we have nothing we can do. We have no control over air pollution. Whatever air purifier we put in has no control. Yesterday, I think there was an article saying a tennis player who came into Delhi to play suffered so much pneumonia and then had to be flown back to the Netherlands. She complained saying, "No more. We will not come to Delhi. It is so polluted. What am I doing? How can I play over here?" So what can we do about it? That is one thing which can go push down the air quality. I mean, make it healthier. As much as possible, control the food. Only when we control can we talk about controlling others. Yes, sir.
All our grains, what we are consuming last 2 decades, it's all genetically modified.
Sir, the thing is, sir, everything is genetically modified, sir. லெமனே ஒரு உண்மையானது கிடையாது. நான் அது மாதிரி இருக்கிறப்போ how can we eat them? So every level of food what we have has genetic modification. Genetic modification may not be inherently bad. The problem is not the genetic modification. Problem is what is added on top after the genetic modification. Okay, sir. Genetic modification is what? Mutation. In a selective mutation. அவ்வளவுதான். நம்ம சாப்பிட்ற கோழி இருந்து வரக்கூடிய முட்டை, மாடு எல்லாமே ஜெனடிக்கலி மாடிஃபைட் தானே சார். அப்படி பார்த்தா மாடு சப்போஸ் டு பி ஃப்ரீ ரேஞ்சிங் கவ் விச் cannot give so much liters of milk. It can give enough for its calf to grow. அவ்வளவுதான். நம்ம அதை எடுத்து லிட்டர் கணக்கில் ஒரு மாட்டுல இருந்து கறக்குறோம். அது ஜெனடிக்கலி மாடிஃபைட் தானே. ஸோ அது நம்ம அதுக்கப்புறம் பண்றது. அதுக்கு முன்னாடியே இட் வாஸ் கிவிங் வே மோர் than even a calf is sufficient, sir. So thing is that our life, everything in front of us is genetically modified. Genetic modification may not be at fault. What is at fault is the additives which you are adding. Anything which you can get from the land, anything which grows on its own is not a problem. செடியை போட்டா வளரதான் போகுது. ஜெனடிக்கலி மாடிஃபை பண்ணி போட்டா கூட வளரதான் போகுது. That means it's still technically natural தான். அதான் சொல்லல. We suffer better when it is lesser. நீங்க பற்றாக்குறையில நல்லா இருப்போம். நம்ம அளவுக்கு அதிகமா இருக்கிறப்ப நாசமா போயிடும். If you can survive on less food, everything else, it is always better. Yes, sir. நம்ம காட்டுல மனுஷன் இருந்தப்ப 3 வேளைக்குமா சார் சாப்பாடு கிடைச்சிருக்கோம். அது ஒரு நாள் கிடைக்கும், 3 நாள் கிடைக்காது. ஸோ அதான் we do not need 3 meals a day. A person can survive on 1 meal, a person can survive on 3 meals. That is their habit. Even on 1 meal it's good enough. The problem is, are you getting the nutrients what you want? That is why we talk about salt. It doesn't matter how much you do, unnika nalika அப்படி இல்லை. On a whole month, stick to 5 grams per day per person. So when I tell my patients, I don't ask அரை உப்பு போட்டீங்களா, கால் உப்பு போட்டீங்களா. I ask them one simple thing. வீட்டில் எவ்வளோ பேர், போன மாதம் உங்கள் வீட்டுக்கு எவ்வளோ உப்பு வாங்கினீங்க? Because it is impossible to fake that data. 4 பேர் இருந்துட்டு ஒரு 2 கிலோ உப்பு வாங்கினாங்கன்னா, you know they are taking too much salt. Even though they may feel their salt intake is less. So it is impossible to control everything, sir. Best thing we can control is everything in moderation. If possible, less than moderation is also better. That is always better in the long term. But the aim should not be for people above the age of 40, 50, 60. It should be from the age of 15 to 20, because that's when habits change. Every generation, the food becomes worse earlier. Again, 3 generations back, we saw illness at the 80s. Why are we seeing the same illness at 60s? Young heart attacks, young MIs used to be a thesis subject for us. My co-PG did a young MI thesis. Now, paradoxically, every patient what we see is an young MI. With the surprise, we see 60, 70-year-old with heart attacks. The reason is because every diet changes கல்யாணம் ஆனதுக்கு அப்புறம். அது வரைக்கும் I'm still eating my parents' food. My parents ate their parents' food only till they got married. After marriage, everything changed. So, if you're going to change your diet, the diet has to be changed for the whole family. That way, at least the children do not have too bad a meal. The same context of good meal continues for every generation. That is what I would recommend. Yes, sir. Yes, sir. Yes, thank you. So this is again same thing with alcohol. Alcohol consumption, as the number of glasses increase per week, every event, not even a single thing gets better. Stroke increases, heart attack increases, atrial fibrillation increases. Now that comes to conclusion. Just a short talk on future. The future may not be so bleak. Like I said, there are so many things which we have no control over. There is no control over what our parents fed us. By the time we realize we are 40 or 30, the damage which has occurred has already occurred. The high salt intake damage has already occurred. There are methods where I can still do something about it after. Now, one way, unfortunately, is still medications only. Now, this is a very nice agent which is coming in the future. We must have remembered all the endothelial antagonists, so the macitentan and all these things, ambrisentan. These are drugs we use for pulmonary hypertension. Now, this is a similar thing, but it's a dual endothelial receptor antagonist. It's actually available right now in the market. Not sure what is the name though. So, aprocitentan. It is very expensive. Everything comes first becomes expensive. The thing is, it has a simple thing. It is once daily dose. It causes nice 20 to 30 millimeters of mercury pressure drop compared to most other agents. The only problem is tolerance is the question mark. That is the only issue. As things get better, this should be more easily used. As of right now, it is recommended as a second or third line agent after the regular antihypertensives. There's still resistant hypertension. We can think about it. Where we used to not be able to give any agents, there are already 4 or 5 antihypertensives. This can work. This is a whole different agent. Now, this is the injectable antihypertensive which is under stage 3 trial, zilebesiran. This is similar. So there is something similar for cholesterol, that is the inclisiran, where you take once in 6 months, your cholesterol drops by half. This is something similar for. These are not exactly biological, sir. They are all called small interfering RNAs, sir. They go in and they shut down a pathway. So cholesterol, it shuts down your this pathway, the PCSK9 pathway. Same way, this controls the pathway for angiotensin production. So again, so most of the antihypertensives right now is RAS inhibition. That's the best thing. So right now, even right now, the first antihypertensive we recommend is either an ACE or an ARB, which is more tolerated, not much significance. So this will cut it off earlier. The advantage of this is an injectable agent which you take once in 6 months or once in 3 months and pushes your pressures down. It looks as a very promising thing. Like it is similar to inclisiran. It is still in trial phase, sir. It will take a while, but it will shortly get approved in next year or 2 years, most probably. But problem is, sir, it will all be very expensive when they come. Right now, inclisiran is 1.5 lakhs சொல்றாங்க. So, but that will cut down your cholesterol by half. பணத்துக்கேத்த பண்ணியாரோ. So it is something to look forward in the future. Maybe it will become cheaper. So once resistant hypertension, you put once in 6 months, once your BP comes up, there is no talk about complaints. 60% only what we are targeting. It can become 100. Hopeful futures. Now, yes, exactly. So I can only suggest. Will they listen or not? We do not know. That is the problem. That is beyond our control. But when I give this, I can control everything. That is the only advantage. But again, I don't recommend giving this. That's only for, again, when it comes in, it will only for recommended for patients who are in uncontrolled hypertension or resistant hypertension will be recommended. So anyway, we'll see how things go in the future. Now, renal denervation is coming back into fame. It is more famous now because the technique previously what we were using for renal denervation has changed now. Right now, they are doing even for the subvascular. So previously, when we used to do renal denervation, we used to take a catheter into the artery because I'm an interventional cardiologist. I like talking about this. So we used to go through the femoral artery. Only around the neck of the femoral artery, ostium alone, பண்ணிட்டு இருந்தோம். Now things have changed. We identified the number of nerves in chain is far more in intrinsic smaller arterioles. So the newer catheters have come in where we target those also. We don't just target the ostium of the artery. We go in through fully and obliterate every nerve. It has shown significant promise. Again, only problem is again it is an expensive thing only for resistant hypertension. The basic for everything is salt restriction, medication compliance, and lifestyle control in this order. If we can achieve these three, 90% of the patients can be easily managed. And we just have to know how to tackle all their questions they ask. So the thing is, sir, there is no published, recognized data which says it is good, but there is nothing which says bad. Point one. Theoretically, it works by increasing your parasympathetic activity, calms you down, reduces sympathetic tone. So theoretically, it is useful. So yes, we do recommend it. But the patient is not even sleeping well when they're not even walking. Doing yoga alone will not replace anything. It is an additive to the therapy rather than replace something else. Only if they walk, sleep, only then can yoga help. If they cannot do that, only doing yoga and sleeping for 3 hours, we are not making any advance. It is an additive to therapy is what I would recommend. Anyone like any other questions?
What about weight training?
So humans, what is every animal has a unique feature in the animal kingdom. Humans are not unique for the brain. Pigs have a bigger brain. Dolphins have even better. They're supposed to be even smarter than us by their amount of neuron firing. Humans are not meant for any of those things. Humans are the only animals which can run the longest. We can outrun any animal in the long run. It is not about fast. We are the only animals which can run for kilometers at a time. You must have seen all those marathons. They get 40 kilometers, 100 kilometers, 200 kilometers. Humans are the only animals we can. For the sake of health, is weight training useful? We are not meant to lift weight. Weight training is not of significant benefit. Lifting 100 kilos is of no use. But what we recommend is 1 hour of aerobic exercise, 10 to 15 minutes of weight training, limited to 10 kilos and lesser, do whatever you want. That makes sense. Everything in moderation. That is more better because when we do that 10 to 15 minutes of weight training, it increases the metabolic rate more. It increases the basic cardiac activity increases. Therefore, as an additive, only weight training is of no use. Aerobic exercise has to be there. We are meant to run. We are meant to walk.
The solest exercise is sitting.
நடக்கிறது பெட்டர் இல்லையா மேடம், உட்காந்துட்டு பண்றதை விட. So
Those who are in front of the system.
sorry madam, I cannot hear you.
In front of systems, all IT people.
It is not a replacement, madam. It is a small compromise. We still recommend 1 hour set aside, do it. That is the only thing. Nothing else helps.
What about playing soccer and rugby to substitute together?
Better. Cricket விளையாண்டுட்டு எனக்கு இது எக்ஸசைஸ் பண்ணுன்னு சொல்றது லாஜிக் இல்லை. பட் டென்னிஸ் இஸ் ஓகே, but not so much because tennis is more bursts of speed. We rather recommend football, basketball. These are better. Cricket is only when you are fielding and running after a ball it counts. When you are sitting and hitting, it makes sense.
Bowling also, you're running in a
Yeah, but you short bursts and then it stops. Short bursts.
one more.
It needs to be continuous. That's why when the patients come say, oh, no badminton விளையாண்டா என்ன பண்ணானே இப்படி இப்படி அடிச்சிட்டு இருப்பாங்க, which makes nothing.
I understand.
So yes. So all guidelines talk about start diuretic earlier. That is better அப்படிம்பாங்க. I never write diuretic in any of my patients because everyone eventually ends up in hyponatremia. They get him. So the only point of my treatment for older patients is I want to avoid admissions as much as possible because every admission will make them deteriorate faster. Everything goes down. We do not recommend diuretics as a first line because of that, and that is the only reason. Not for it. It is an excellent antihypertensive. Volume shrinkage is useful. I personally always start in ARV and then CCV and then light edema.
Medication you're not talking.
ஆமா அதுக்கு வரல அது after that because mythsல வந்து அது வராதுல்ல. So the salt restriction what I talked about is for a patient not on a diuretic. If a patient is on a diuretic, it is different. In a person not on a diuretic, absolute salt restriction, zero salt பண்ணுங்க ஒருத்தே இல்லைன்றேன் நான். If a patient is on a diuretic, please take 4 grams 5 grams அப்படின்னு சொல்லிடுவோம். Because diuretics will make your hyponatremia worse, hypokalemia worse. In a non-hypokalemic patient, non-diuretic patient, salt restriction will not affect their sodium. Because there is nothing which will affect the RAS, so hyponatremia எல்லாமே இங்கே ஒண்ணுமே வராது. That is the logic. So you want to talk? We'll go into the talking about hypertension treatment next. So guidelines for antihypertensive treatment is simple. Any patient who comes to us, we talk about dual agents only. Preferably always start as dual agent therapy. Next. There will be a lot of data here which I'm going to skip. Next. So the guidelines wise, the recommended antihypertensive intake is either an ACRB combined with a CCB first. They recommend diuretic. We do not recommend adding a diuretic initially because of our incidence of hyponatremia. So Africans actually tolerate diuretic better than us. Salt it is possible, sir. All my heart failure patients are doing well with no salt to 1 to 2 grams salt. If they can do it, it is possible. Only thing, you have to get over the first 1 month. So that is why we say don't go to zero salt in those patients. At least stick to 5 grams. If you can achieve 5 grams in them, that is itself more than enough. See, lesser of 2 views. Ideal world.
So step 1 is ACA.
So step 1 therapy is always preferably start combination therapy. Start combination therapy with ACRBs with either a CCB or a diuretic is what they recommend. We do not recommend diuretic because of hyponatremia risk, volume contraction எல்லாமே. We instead prefer in patients who are uncontrolled despite of therapy, those patients we want volume contraction. அவங்களுக்கு we say add diuretic as a third line. It is better tolerated because by the time amlodipine போட்டு pre-edema வந்திருக்கும். Light out சின்ன low dose CTD ஏதாவது போட்டுட்டோம்னா கரெக்டா pressures இறங்கிரும். So that will be the ideal way. Yes sir.
Why diuretics Africans tolerate?
Renal tubular pathway sir. So there were multiple trials. Again, the same way for us for this thing. They said Africans don't tolerate. African Americans tolerate diuretics better. So their explanation was they were working so much on the cotton fields, they had more water intake than salt intake. For them, it is more about volume excess than volume conduction. It is because the kidneys for them, the African Americans, developed in such a way that they were tolerating diuretics more, they wanted more water excretion rather than salt as an issue. But Africans sort of genome is more close to us. They tolerate regular antihypertensives like a regular population. That's why the AHA guidelines, when you say African Americans, they will recommend diuretics first of all.
ARB, CCB, single dose or
combination, together. And always prefer as a single pill combination, sir. Always single pill combination. Single pill combination, sir. The reason is because compliance issue. When we give 5 tablets, they are not going to take it. When you give 1 tablet, they are more easily prone to take it. There are lots of studies which say single pill combinations are much better than polypills. Yes sir.
Tell me certain
Amlodipine, cilnidipine combination இருக்கு. எல்லாமே இருக்கு sir. So there are triple drug combinations also, sir. So easy way na sir. There is that one Tata 1mg app where I don't know all the combinations which there are. Every month they have new combinations. என்னெல்லாமோ வித்தியாசமா combinations. So what I do sometimes, sir, when I don't know which combination, which company, I just go into Tata 1mg. I type the tablets I want. Tell me sartan with cilnidipine with hydrochlorothiazide quota. It will give a list of tablets which companies with single pill. We don't need to worry about which is there, which is not there. It will also give us a combination, sir. It is easy, free, cheap. It takes 30 seconds. So easy way. Technology allows this. Cost is zero. I agree. So, sorry, sir. For antihypertensive management, madam, nothing. The exceptions are only for two, madam. Age more than 80. Point two, patients who have this thing, acute stroke, where you want a higher perfusion pressure to be maintained. These are the only two in the exclusion. Otherwise, bring it down. There are. I am very aggressive for BP control, madam. I try to maintain my pressures always over less than 130 systolic and below 80 diastolic. But I don't aim for the 80 diastolic. I'm okay with 80 to 90 diastolic also. But I try to, as much as possible, push it down. Sprint try. Sorry. I will come to that next. So, dual that. I will tell that. So, trial, madam, showed pushing pressures down less than 120 even had better outcomes. Only problem, they ended up having more renal dysfunction, more symptoms. They kept having syncope, all of this. That's the only reason our pressure recommendations are not 120. 120, but all these company people will be happy because numbers of prescription will be high. But once your systolic pressure became less than 120, the method for us to control the pressure right now is still not good enough. When we control it too much, we ended up having too many complications. But trials showed less than 120 had better long-term outcomes for the heart, endorphin intervention. We always, again, lesser of two, you manage both. Point one. Point two. So you asked something.
ACI or AR?
Yeah. So the first line of therapy advised is AC inhibitor. They recommend AC inhibitor because it is more studied than ARB, because it is earlier, older, all of those things. But how we use is AC is better for remodeling nephropathy production. Once you want more BP control, I personally prefer ARBs more. One, because it is easier to get combinations. AC combinations are less likely. Now, is there any patients where we use single therapy combination? Those treatment naive new patients who are like 20, they just come in. Those are patients where I would prefer just a touch of antihypertensive, where I don't want significant control. For 140, and they also respond extremely well to antihypertensives. Those patients, I'll give a very small dose of an antihypertensive, either telmisartan preferably or amlodipine alone. That is what we usually start. Or if they just have excessive tachycardia, that's what we most commonly see. Heart rate will be 108 when they are otherwise calm and collected, and the pressures are some 140. Those patients, I'll just put a beta blocker and let it be. No, previously they used to say beta blocker only for patients who have heart disease. Otherwise, don't use them. Things have changed. We can use beta blocker also, but again in moderation in selected patients. If the heart rate is already 70, we won't prefer what beta blocker we put. And it does the yes one. Again, they did a trial. They compared loop diuretics versus thiazide diuretics, for which caused better hypertensive. We would. Yes. One guideline what we do in practice. So what I recommend, sir, make the patient sit down, talk to them for 5 to 10 minutes, and then measure the BP. Even then, measure twice is what I would recommend.
So doctor takes the BP, the nurse takes the BP.
So the problem is we rely upon if they're doing a correct job or not, sir. I have this OCD where I want to check everything myself. So if we don't know if they're doing it correctly, I will check it. It is not possible in practice. Or TV பார்த்துட்டு the phone side பேசிட்டு இருப்பாங்க, TV பார்ப்பாங்க. It may not be possible. Yes, it is better, it is easier, it may be even better, but the thing is, I would still say check ourselves. But do not check வந்த உடனே check பண்ணலாம். ஒரு 10 minutes விட்டு talk to the first pressure எல்லாம் விசாரிச்சுட்டு அதுக்கப்புறம் pressure பார்த்து எடுத்துட்டு பிறகு and then recheck the pressure. If they are still high, send them out, make them sit for 30 minutes, recheck the pressure again.
So that was how we manage it. But what I find is when they come with a plate composed therapy, at the time when we check the BP is very low.
So the thing is, it is bled out.
Generally, they give a sedation and then they give it to the physician to manage. But I just
So I would say
label a hypertension.
to label a hypertension, it is two separate readings in two different instances. So what guideline says, if I see a person with high BP, we don't start therapy. Unless it's like stage 2 hypertension, number 160, 190, அது மாதிரி போனாலே ஒழிய we do not start. 140 இருக்குன்னா, you send them home, call them back a different day. That's what guidelines say. Check the BP again. And then if it is still high in two separate readings, then label them as hypertensive, start therapy. Again, it is not.
Which is the better position? Sitting, lying, or standing?
So extensive trials have been done. There is even a difference in pressure measurement when we sit and keep the hand on the table versus leaving hand out. The correct answer is not there. Every time a new guidelines comes, it changes. My recommendation, whatever we do, measure always the same way. If you're going to we always say sit, keep the hand on the table, wait, and then measure. Measure the same way the next time and every other time. So same every time measure the same way, then it is okay.
What about emptying the bladder and other criteria?
By the time they're sitting in the OP itself, their bladder would have been empty because they're waiting for us. So obviously, they should not be in respiratory distress. They should not have acute illnesses. In acute illnesses, pressures will obviously be higher. When you see a patient with their treatment naive, they have something else going on, leave it. Recheck.
Pressure is only on lying down. Highest pressure.
I agree, sir.
So ideally, you should do the lying down.
But you are not living life lying down, sir. You are not living life lying down, sir. So we cannot take that as a thing. And it is again, we have to moderate between clinical guidelines and what is possibly there in clinical practice. We cannot have the patient lying down every single time to measure BP. It is not possible. And
My professor of KVT used to say, make the patient lie down and take the PCR.
KVT sir in the காலத்துல பண்ணலாமா பண்ண முடியாது. So right now, my recommendation, however you measure, just not obviously in an acute illness, don't make them stand and measure obviously. But every time, do the same measure is okay. So if the weighing scale is broken, every time it will show the same broken measurement only. But at least the broken measurement is going to be the same amount of broken. So at least you know what the guidelines says. Exactly. Sorry. So as I was saying, madam, sorry disturbing about getting a bit distracted. So they actually did a trial of comparing thiazide versus loop diuretics. We would paradoxically think thiazide diuretic is better, it causes better hypertension. Actually, loop diuretics cause better pressure drop. But the problem is it also had same amount of sodium loss. So it does not matter what diuretic we use, madam. Because we do not have combination pills for loop diuretics with other antihypertensives. We don't have like telmisartan with furosemide. So where do we go for that? So whatever antihypertensive we use the same combination which is available. The amount of difference is only in the long run. It is not in the short term. So it is okay. It is fair enough to use any diuretic what is available. Only thing, when you are starting to use diuretic, don't worry about the BP at that time. Worry about the hyponatremia. Because one episode of hyponatremia and admission is hell for the patient. Because after that, it is very much harder to convince them to reduce the salt intake again. High salt and dietitian will randomly come and say, oh, your sodium is low. Please take 8 grams of salt, 10 grams of salt. And for life, they will take 10 grams of salt. So when we start diuretic, I would say, look for hyponatremia. Avoid hyponatremia at any point. If the sodium falls to 130-ish, stop the diuretic. There are better agents available. There are better methods available. We can go to that. So the thing is, sir, my patients are slightly biased because most of them end up developing heart disease before they come to me. So they are slightly more compliant for salt. And I keep my visits once in 3 months. So the 3 months once another unit test because doctor they control the salt. And I don't recommend the salt intake to the patient. I tell the family member, I tell the person who's cooking. If we can tell them, they are the true power of cooking and they can control everything. If it is a wife, talk to the mother. If it's a male patient, talk to the wife. They will truly control everything. That will be the easy way. Because there's no point talking to a male patient saying, cook. If I have a cook at home, வாங்கி கொடுக்காதீங்க. வீட்டுல யார் மல்லிகை ஜாமான் வாங்குறாங்கன்னு கேட்டுட்டு அவங்ககிட்ட சொல்லிடுவேன். That is the way forward. Yes, sir. So again, I was talking about that non-compressive BP measurement method, sir. They actually work based upon the volume of pulse. Logically, it makes sense. Pulse volume will correlate, but it does not, sir. It does not pulse rate. Patient has fever, they have bounding pulse, we cannot take it as much. There's a lot of other variables. And slightly older patients will have an atherosclerotic vessel, it will be nice bounding, but pressures will be normal or slightly high normal. It doesn't correlate directly, sir. Again, convenience, sir. However you want to use it. The difference between diuretics is present, but not significant enough for us to worry about in current clinical practice, sir. 5க்கும் 4க்கும் வித்தியாசம் கிடையாது, sir. Only thing, hyponatremia is, I used to write perindropal previously a lot. Indapamide a lot before. I had very bad experience with hyponatremia, so I stopped writing it. And then I switched over to hydrochlorothiazide. I had again similar, but it was not that bad. So right now I prefer hydrochlorothiazide for all these antihypertensives, and moreover it is more easily available, cheaper. Natrolix SR is extremely expensive. Adukku idha potu poite irkalam. We also have to take into consideration other things also, sir. Theoretically speaking, there is a difference, but for clinical speech it is of no use.
Hypertension in body is that we should have 8 hours sleep. You know, after 60 years, nearly 50% of the people have BPH. So how they can sleep for 8
So
hours?
the aim is, sir, if we can do it when you're younger, your pressures would have been much better now. Then I am not worried if your sleep will disturb now, sir. And any patient of mine, when they come in, I ask them, are you waking up at night to pass urine? If you are, irrespective of prostate size, I might as well put a small dose of Urimax or Urimax because if I can push down the 3 episodes of waking to 1 episode of waking, it is still a better quality of sleep than absolutely nothing. It is impossible to go to 0. We have to accept our limitations. I am okay with 1 episode of waking up at night. And adayum as close as possible to the 5 o'clock, 4 o'clock, I'm happier. I would rather say go to sleep earlier and slightly push over to the waking up time, sir. That's what I would recommend. I would concentrate on 40-50s to sleep for 7 to 8 hours. At that point, at 60s, your disease is already established. I am more concerned about control of everything rather than negating everything.
But it's fine. In old age, apart from the hypertension, there are a lot of mental worries, tension, and he is afraid that, I know one doctor, he would not sleep in the night because he thought he would die. Then he will sleep in the night. He will ask, go for night duty. Okay, he select night
In the
duty.
daytime, if
And
we
then-
can sleep 7 hours continuously, I'm happy, sir.
Are you happy, sir? Nowadays, this iPad, iPhone, whatever it is, seeing news, and news is always trend. How far it is practical, especially for old people? No. Just for discussion.
The thing is that it is still possible, sir. Other than that, before going to sleep, 2 hours before, cut out every monitor, throw it out. That's number one. Point 2, keep the phone outside. Phone வெளிய வச்சாலே பாதி பிரச்சனை போயிடுச்சு. Point 3, keep the room quiet. Make sure there is no wide fluctuations in temperature. There is a fan coming and going or some noise, mosquitoes coming and separate intake. Control all of those. And make sure there is no reason to wake up. One time episode waking up is okay. If they're waking up multiple times, address that. If it is a prostate, fix the prostate. It doesn't matter if the prostate is small or big. If it is causing nocturia, it is significant, treat it. See, that is irritable bladder syndrome, sir. Adukku treatment irukku. Adum kudukanum romba. So for them, more of water restriction before going to sleep will help better. So irritable bladder will only work when it is getting stretched. Let not stretch. Let them slightly be dehydrated before going to sleep. And everyone has that habit of drinking water after you come back from the bathroom and then sleeping. And then 2 hours you திருப்பி நிரம்பிடும். So that is because we have that mouth dryness at night, because we inevitably slightly keep our mouth when we are awake. So easy way, keep a cup of water, but only cup of water. So you can only moisten your mouth. You cannot drink water. அது மாதிரி வைக்கிறது better.
The sodium Tata Light, the creatinine is alright. Do you recommend Tata Light?
So the thing is, sir, we assume Tata Light is potassium salt. யாரு சார் செக் பண்றா? The problem is we don't know, sir.
Okay, in abroad, there is low salt is there.
So that is the potassium salt.
40% sodium. But they have stricter control.
Except for renal failure patients, even in renal failure patients, we can check periodic potassium check பண்ணாலே ஒழிய, we can still take. Except for renal failure patients and patients who are on potassium aldactone, all those things, potassium sparing diuretics. Except for these two patients, you can freely give. Again, the problem is our salt. We don't know if it is truly potassium salt. இதுக்கு உப்பே போடாம சாப்பிடலாம்ல சார். யூஎஸ்க்கு போயிட்டு நான் சால்ட் வாங்கி வருவேன் சார். துபாய்க்கு போயிட்டு you cannot take 10 kilos of salt to sir. பெட்டில எல்லாம் பாத்தீங்கன்னா unmeasured salt. இந்த சைடு அடிட்டிவ்ஸ்ல வரக்கூடிய சால்ட் எல்லாம் we don't measure. We say oh we taking salt கம்மியா, சைடுல இந்த கொடை மிளகா மோர் மிளகா எடுப்பாங்க, ஒரு ஊறுகாய் போகும், சிப்ஸ் போகும், அந்த லேஸ் இதெல்லாம் சாப்பிடுவாங்க. All these are unmeasured. So when we say salt restriction, we have to tell them first please cut the salt. அதை கட் பண்ணாலே பாதி பிரச்சனை வருது. But ideal is less than 5 grams or வைக்கணும். Yes madam.
One neurologist was suggesting that 1 or 2 glasses of water just before to went bed avoids stroke incidents.
So thing is madam, that is because of dehydration. So எல்லாரும் பார்த்தீங்கன்னா கடிவாளம் கட்டின குதிரைகள். We all worried about our own organ. Cardiologist போனா ஹார்ட்டை பத்தி மட்டும் பேசுவாங்க. கிட்னி டாக்டர் போனீங்க. So if you go to the urologist for prostate patients, they will say restrict your water intake, take only 1.5 liters a day. அப்படிம்பாங்க. So everyone, we have to balance everything out, madam. The neurologist, why they are talking about that is because unlike the heart, there is no method of preemptively checking for it. ஹார்ட்டுக்கு ட்ரீட்மெண்ட் பண்ண முடியும், சிடி பண்ணிக்கலாம், உங்களுக்கு இது மாதிரி ஒன்றும் கிடையாது. அது மாதிரி பண்ணா கூட there is no method to control it, because over there apart from plaque rupture, vascular activation, அதாவது platelet aggregation is a bigger problem for them. So they say dehydration உட்றாதீங்க, but not significantly so. When you are not sleeping, the chance of risk grows up more than by drinking water or not drinking water. For that, I would rather say sleep and control your better, BP better. So stroke risk by BP control is lesser. And 1 cup of water, unfortunately, is not much help, madam. It doesn't control much. Atherosclerosis, vascular atherosclerosis. So the vessel wall is so thickened, the systolic pressure மட்டும் தூக்கும், diastolic pressure will be persistently low. If we can find a measure to increase the elasticity of those vessels, then they will be fine. But again, we don't have a way to reverse aging. Most common cause of that is aging, vascular aging. There is no method we have currently available for controlling vascular aging. Yes, ma'am.
We have 40 more slides.
Those are, we don't need to do that, madam. That's okay. As the first step, just with the side. Those are all only theoretical data. This will not make sense. Play panna.
Maybe we'll have the questions at the end.
No, we're not doing those slides, sir. You're stopping. Those are all for company related slides. That's okay. Yes, sir.
Insufficient drinking of water, does it cause muscle cramps?
So, if you're developing cramps, it is because of dehydration. But I am recommending not throughout the day. Night, before sleeping, cut down your water intake 1.5 hours before going to sleep. So in the day, please drink plenty of water. That's better. These are all very old slides. How do we start therapy? We start amlodipine or ACE inhibitor. So right now, these guidelines don't mean much. The guideline says start any antihypertensive you want, however you want, get the BP down. That is all. The other recommendation of starting ACE ARB is more a suggestion than actual guideline. If a person again is tachycardic, heart rate of 140 and pressures are 150, it is better to give them beta blocker even if they have no heart disease. So every decision to start antihypertensive has to be an individualized decision and not bedside medication. It's not like, oh, every time I'll start only the same agent. That is all. Next.
It's like C and D comes for the elder age.
This is previous one. Again, not really, sir. So, patients' antihypertensive requirement varies. What works for one will not work for other. Older patients, it is more because of atherosclerosis and elevated adrenergic tone. Those patients, RNA would be, ACE inhibitor would be better. The only good thing in this you have to know is if the patient goes in for resistant hypertension, no patient is already on 3 antihypertensives, the pressure is not controlled, you can consider mineralocorticoid antagonists. So aldactone is a good choice to add. You will not expect them to control BP. It actually does. It is a nice add-on antihypertensive, but not as a solo agent. That is the only thing about this thing. So all these are just company provided slides. I would not recommend for any of these things. Okay, because these are all just diet. Say again, when you're not controlling diet, what antihypertensive you give to control the antihypertensive BP doesn't matter. Okay. இதெல்லாம் ஃபுல்லா நம்பர்ஸ் இருக்கும். Switch. So any doubts, any questions anyone would like to ask?
Depending upon the age, what's a normal hypertension patient?
Sorry, sir.
Depending upon the age, middle age, old age.
Only one age, sir. 80 and above மட்டும்தான் we have leeway of pressure being higher. Anyone 80 and below, it is above the age of 80. Like 80 and below, it is still the same. Preferably get to 130, 80. Maximum 140, 90 and below. That's
80,
it.
80 and above, you don't have to worry.
No. Of course, the recommendation slightly relaxes to 150 and 80. That's all. We are not too aggressive because at that age we are more worried about complications of antihypertensive therapy. We don't want them to have a fall. We don't want them to have syncopal episodes. Or we don't want them to develop renal failure. You cannot put an 85-year-old on a diuretic and they're already volume constricted. They won't drink enough water. They'll develop renal failure, it becomes a problem. At that point, we'll be more relaxed in controlling the pressures. Or amlodipine, we can wait and watch. We will be happy with the pressure of 150 and 80. We won't be very aggressive and control those patients.
Amlodipine better or sildenafil?
The amount of pressure reduction is slightly more in amlodipine, but the symptoms, complications are more. Renal edema is more. There is also a component of proteinuria in the kidney, which is slightly present in amlodipine, which is not there in sildenafil. Nifedipine has none of those things, but only problem, nifedipine has a risk of causing reflex tachycardia. So everything has to be adjusted into that niche patient, sir.
So the beta blockers, bisoprolol or metoprolol?
Bisoprolol, I would prefer bisoprolol as a cardiologist because there was actually a trial in acute MA patients. They gave metoprolol, bisoprolol. They tried gave all those combinations. What they noted was patients who were giving metoprolol was an increased stroke risk. It did not correlate why, they were not able to explain why. They just said there's an increased stroke risk. Therefore, cardiologists started preferring bisoprolol more. So if a patient has heart failure, I would prefer carvedilol. If the patient has MI and any other, even for antihypertensive control, I would prefer bisoprolol for management. And they're better tolerated also.
This beta blockers, these patients' BP is controlled, but more chance for stroke.
Metoprolol, sir. Yes, sir. Yes, sir.
What I am asking, suppose the patient is taking metoprolol for 10 years, 15 years, how to stop it and switch over to this amlodipine?
Don't stop, sir. Let it be.
Let it be.
Let it be.
If you say there is a chance of stroke,
That was in a trial in acute MI when they compared metoprolol versus bisoprolol, sir. If they are already taking, they are already tolerating, leave it. Why are you messing? If their pressures are not controlled, then we can add on.
BP is controlled,
Then leave it, sir. Leave it, sir.
very long time.
Yes, sir.
20, 30
Yes, sir. That's what they recommend, sir. Age above 80, if the pressures are already 130, 120, you will not withdraw medications to push it to 150. If they're already tolerating antihypertensives well at the age of 80 to maintain at 120, 130, you will not de-escalate therapy also because guidelines say 150 or same reason. If they're tolerating well, leave it.
After sometime I read one article by a doctor who was a professor of medicine. And he was advised by his friend, who is also a professor of medicine, for 130 by 90 some BP medicines. He wrote a beautiful article. I don't know why, who made this BP 120 by 80 normal. And by taking this anti-hypertensive medicine, I become very weak. Also, I become sexually very weak. I feel my life is doomed. How do you
So-
made up this article?
Beta block. So of all the antihypertensives, beta blockers have a higher chance of causing erectile dysfunction, feeling of apathy, எல்லாமே. So those are the patients we take away the beta blocker, put some other agents, we are done.
எப்படி beta blockers suddenly stop பண்ணாங்க?
But you're not taking that for a long time, sir. So, and that way, if the patient has a heart disease, if they have an acute MI, you're not worried about sexual activity. You're worried about surviving the MI. Those patients, beta blocker is more important. In acute MIs, we're not going to be adjusting the beta blockers. In stable patients who are atenolol is the one biggest culprit. When we stop atenolol, you will have this reflex tachycardia which stops. That is difficult to control. Except for atenolol, any other antihypertensive can be switched to other or lesser. Only thing we monitor the heart rate, make sure it doesn't shoot up. That is all. So it should not be an issue. And if they have symptoms, whatever the agent may be, change it, sir. Even if it's ACRB or CCB or very safe antihypertensive, if they have any symptom, it is worthwhile changing it, sir.
Hypertension before was used left, right, etc. Now it's slowly going at. Who is going?
The reason is,
Disorder, etc. Just great.
so it's similar to SGLT inhibitor, sir. US they use exclusively empagliflozin. Our usage empagliflozin is almost nothing. We only write dapagliflozin. The reason is it's already a little bit pharmacology company motivated also, because they promoted dapagliflozin more because it came out of trial earlier, it's cheaper more than that. Same way, antihypertensive also there is a heavy bias by the industry. But atenolol is an extremely old agent, and the biggest problem I have with it is because it gets excreted very quickly. And most patients with renal failure, when you give atenolol, they have extremely bad cardiac. The heart rate is always 40-50. And atenolol is an agent we do not use for BP control, it is more for heart rate control. The amount of BP control it does is negligible. There are better agents available now, then why are we not using them? That is good.
Blood thinners we given to all hypertensives.
So we're talking about primary prophylaxis. As of right now, guidelines wise, there is no indication for primary prophylaxis except for maybe diabetics. In diabetics, we explain to them the risks of bleeding. So there was a recent trial 4 or 5 years back which studied the primary prophylaxis, what happened when you give aspirin. It was a very big trial, forgetting the name of it, where they identified when you give aspirin, yes, there is a reduced risk of primary CV event. Bleeding risk went up. But the problem with the trial was they combined bleeding risk in all forms. They had gastritis, they had strokes, they had everything. If you're asking me, would I rather have gastritis, ulcer, bleed, or heart attack? I would rather take the ulcer, bleed, than anything else. Because unlike the US, we have very, very high incidence of pantoprazole intake. Almost every patient is on pantoprazole, and there was some patient. So for us, the incidence of GABs would be lesser. So always talk to the patient, explain to them this is the issue. If you are okay managing ulcers or ulcer-related issues in the future, or bleeding issues, this is better. The problem convincing them for long term is the effect takes a very long time to show. It takes 10 to 15 years for them to avoid a CV event.
Those who are stuck in
What about statins, sir?
Sorry.
What about statin in hypertension?
So
Above 18 we have to give statin.
if they are already on a statin therapy and they are tolerating it well, don't remove it. If they are frail and they do not tolerate statin therapy, don't even encourage it, because we have alternate options is there. Statin wise, we aim for only one thing. We don't care about triglyceride, we don't care about HDL, we don't care about what calls nothing. We worry only about LDL. Aim for an LDL less than 100 in anyone and everyone. If you have some risk factor, say diabetic, everything, aim for less than 90, preferably less than 70. If you have even one event, stroke, heart, anything, aim for less than 50. If they're above 80, if they've had no event, if they're able to tolerate, a low dose statin can be considered. But if they are very frail, it does not matter. Just eat. Muscle weakness. Only symptom we are worried about in statin, madam. Muscle weakness, body pain. If you have statin-induced myopathy or statin-less fatigue, it is not worth it at above 80. Stop the drug and move on. But if you had an MI and you are asking, definitely patients should be on statin and they should be on high dose statin. Because the reason for statin is because they will have other atherosclerotic plaques anywhere else. Rupture, stroke, heart attack, another issue. For that reason, statin would be recommended.
They say tablet of aspirin to relieve natural skin. So the patient thinks he got some MI and like that. If you take this tablet, you can say
So, the original trials for antiplatelets, dual therapy of antiplatelets, loading dose of aspirin, clopidogrel, statin does not matter. Aspirin and clopidogrel can avoid spontaneous recurrential vascular rates as high as 30 to 40%. But the problem is 30 to 40% is not enough for us to generalize it here. If there is some way I can say it is 90%, 80%, it is worthwhile for everyone. So what we recommend is, if you have a chest pain, go to a doctor. ECG eduthu MI mari irundha, it is better to give. If they have an ulcer, you give loading dose of aspirin, they don't have to bleed, it becomes a no. So for general public, I will not recommend them carrying an antiplatelet dose in their pocket. But if you're a doctor and you're carrying it out, and patient you know strongly think it looks like a heart attack, the diaphoretic pulse becomes 30, BP is low, and they have severe crushing pain, it is worthwhile giving. The problem is ulcer, acute GI ulcers will have similar symptoms, exactly like an angina pain. That is the issue. But yes, 40% spontaneous recorrelation occurs if you can give antiplatelet loading appropriately. For that, we have to crush and give the tablet. You have to tell them to chew and swallow. Yes, it helps. Actually, paradoxically, the thought has changed. We now recommend not aspirin but clopidogrel for a longer duration. So what we write, we used to do DAPT, post-setting 1 year DAPT, and then we reduce the DAPT to single antibiotic. That single antibiotic used to be aspirin. Aspirin was causing a lot of ulcer bleeds. Therefore, they did multiple trials, they tried comparing multiple agents. They come to the conclusion, switching over instead of aspirin to clopidogrel post-therapy is even better. Well, P2Y12 inhibitors as a whole, clopidogrel resistance is a separate issue. We talk about all P2Y12 inhibitors in the long term is much better than taking aspirin. So, for post-prophylaxis, post 1 year post-MI, switching, keeping on single antiplatelet, which is a P2Y12 inhibitor, is recommended. It is better, yes.
So how do you manage the physical hypertension patient? Is that one milliliters order?
Ambulatory BP, madam. So these are the patients where we have to suspect whether the patient really antihypertensive or not. Those are the patients where we have to, because that is most probably white coat hypertension, or they're just extremely anxious. So those are the patients where we say do nothing, put ambulatory BP, go away. Okay, and we if the home measurements average or peaks occur, and then we manage. And
Spikes only are dangerous.
So that's why those spikes, first we have to prove there even was a spike in the first place, and then we do an ambulatory BP, identify if it is there. If it is there, you're hypertensive, put antihypertensive, walk away. That's all, madam. First, we define elderly. How old, according to you, is elderly, madam? Above 80, less than 140, 150, whatever it is, leave it. Anything else, if the patient's BP is more than 150, whatever may be the cause, treat it. That's all. Lifelong. However long they want to live. Obviously, we'll be checking them periodically, madam. We aim for below 150, not at 150, below 150. 150 is the cutoff. So when we talk about regular BP, we don't maintain at 140. Yeah? We say below 140 maintain. Same way. below 150. That is what we say.
Less than 80, less than 80.
Diastolic, madam.
Less than 80 years. This, what is the limit?
140. Systolic 140, diastolic less than 90, preferably 130 and 80.
65 to 80.
Makes no difference. 80 தான் ஒரே cut off, nothing else. CCB. During hypertension, during pregnancy, Lebetular, nothing will happen. You can do whatever you want. After lactation, doesn't matter again. CCB is safe enough. Nothing will happen, easily controllable. Use this. Theoretically, I cannot tell, but what do we use? We don't use this. Lebetular, easy, simple. It will more any hypertension will control. Tachycardia, pregnancy-induced tachycardia will control. Ore color both are controlled. Post delivery, comfortably we can change over to CCB. Life goes easier. Oh, we never ever recommend sublingual nifedipine because sublingual nifedipine causes reflex tachycardia, and then the patient, that is a separate headache. Their heart rate will be already 100, pressures 140, 140, 150. Sublingual nifedipine pressures will control, and then they will have 120, 130, 140 heart rate. It becomes a headache. So we never recommend sublingual nifedipine. If you're going to give nifedipine, tell them to swallow. Wait. If they are asymptomatic hypertensive, we can slowly control it over a course of few hours. It doesn't hurt. We don't recommend at all. If you want to give something sublingual to control nitrate, 5 mg, 10 mg sorbitrate, a little bit it will control, get the job done. Manageable.
Good compliment.
Any more doubts? Any other doubts? I think it's made very clear. Everything. Give a big hand to Subash. Thank you very much. Thanks a lot. Now, Glenmark, can you just come?
Very good evening to all. I would like to thank Mr. Dr. Subash sir for the wonderful presentation and the information. Thank you for the guidance, sir. And I know this is Sunday today. Thank you for everyone to attend this meeting today, sir. Sir, thank you for a very interactive session. Thank you so much, sir.
Yeah, coffee and tea with bonda is available. Yeah, okay. Just now we had lunch. If you have place in your stomach, please go ahead with that. You should make saltless bondas, then nobody will take it.